Hey everybody, good afternoon. Thank y'all for being here today for the webinar, The Waiting Period, Baby Blues and Beyond, Bridging the Gap Between Clinical Care and Perinatal Experience. May is Maternal Mental Health Awareness Month, and it's the time to recognize that maternal mental health disorders are the number one complication of childbirth, affecting 1 in 5 mothers. And with that, there's help, hope, and healing that's available. And today's presentation is hosted by two projects within Vital. First is the Every Step project, and I'm the project manager for this project, and we work with the Alabama Department of Mental Health and Alabama Department of Public Health to provide expert implementation support in our communities and that provide services to women across the state in an effort to identify and address substance use and mental health needs among pregnant individuals. And the second host is Project Zero Suicide, and we have Jordan here, project coordinator, to tell us a little bit more about Project Zero Suicide.
Yes. Hey, everybody. Can y'all hear me okay? I'm in the car driving back from Mobile, so I just want to make sure that my connection is good enough.
Yeah, we hear you good.
Okay, perfect. So yes, I am the research project coordinator for the Zero Suicide Project. Project Zero Suicide is a statewide initiative that helps healthcare systems and communities across Alabama to hopefully strengthen the suicide prevention efforts and make suicide screenings a normal part of healthcare visits. So the idea behind that is that suicide is preventable when people have the right support, training, and resources in place. The program gives healthcare providers tools and guidance to help identify people who may be struggling and connect them with support and follow-up care. This is especially important just because many people who die by suicide had seen a medical provider within the month before their death. So, catching those warning signs early through routine screenings can truly save the lives of our community members. We also focus on making sure everyone involved in patient care feels prepared and confident in responding to suicide risk to help create safer and more supportive healthcare environments. So our team is working across the state, especially in rural and underserved areas, to improve the access to mental health care and make sure people can get the help they need when they need it. We also just do a lot of community engagement and outreach and events and things like that. So if any of you guys are interested in the services we provide, I will go ahead and drop my contact info in the chat for anybody who may need that. And you can always reach out to me for anything that you may be interested in. So I'll go ahead and do that. And then I will hop off just because I am on the road. But I will be looking for any of y'all's contacts. Thanks, guys.
Awesome. Thanks, Jordan. And then y'all can visit vitalalabama.com for resources for both professionals and individuals for in the community. And then you can also find more information about the free Connect app that we have on our website as well. And so just a little housekeeping, all virtual, all the attendees here, you'll be muted and your cameras will remain off throughout the session. And if you have any questions for our speakers, please use the Q&A box. We'll be collecting those and addressing them during the Q&A session at the end of the discussion. And if you experience any technical issues during the session, please put a message in the chat box to Vital or contact ecwright@ua.edu, and we will drop that in the chat, I believe. So, all right, so here we are. I'm so excited to introduce our two presenters today, Miss Courtney Benjamin and Chania Mitchell. Sorry. Courtney Benjamin is a licensed professional counselor supervisor in the state of Alabama, specializing in perinatal mental health with new and expectant parents. Additional passions include her work with other therapists and first responders and individuals and couples navigating trauma and anxiety. She possesses over 15 years of counseling experience with a myriad of populations and also engages in clinical supervision, preparing others within the field to practice independently and continue the work. She has attained a certification in perinatal mental health and is passionate about supporting individuals pre to post conception and birth. This includes individuals, couples navigating fertility struggles, pregnancy-related adjustments, birth trauma, as well as postpartum conditions like anxiety, depression, OCD, and adjustment to changing roles. Beyond that certification, she seeks to consistently refine skills for use with this population by constant consumption of specialized training to enhancing practices utilize blending specialized training with years of experience. Some of these specialized areas of training include EMDR during the perinatal period with Touchstone, EMDR with complex trauma through Thomas Zimmerman, EMDR Cleveland, EMDR with couples, Flash 4 Blinks version, and emotionally focused therapy. Her work encompasses a combination of compassion, evidence-based, trauma-informed care aimed at ensuring that those within the perinatal period and beyond receive the quality, person-centered care needed to support them from their current chapter into the next. And so that's about Miss Courtney. Thank you. If I don't say it, which I'm sure I will, thank you for all that you do because that is this is all great stuff, and I know your value to your community. And Chania Mitchell is associate licensed counselor, is a trauma-informed clinician and mental health educator whose work focuses on perinatal mental health, trauma, grief, OCD, and major life transitions. She has completed specialized training in perinatal mental health through Postpartum Support International, EMDR for perinatal and infant mental health through Touchstone, and holds training in AEDP Level 1 and inference-based cognitive behavioral therapy. She's also trained as an end-of-life doula through INELDA, which informs her approach to caregiving, grief, and the emotional weight of life transitions. Her clinical approach integrates trauma-informed, attachment-based, and evidence-based modalities with particular focus on supporting individuals and families navigating pregnancy, postpartum adjustment, and complex trauma within underserved and rural communities. As a mother, a Black woman, and someone rooted in a rural Southern community, she brings both professional expertise and lived perspective to conversations about stigma, access to care, and the gap between clinical systems and the people they are meant to serve. And thank you to Shania, amazing, amazing woman here. I'm so excited to get this thing started. I'll go ahead and start sharing my screen, and yeah, let's get to it. I'm gonna mute myself. If y'all need anything, I'm here in the background.
All right, thanks, LB.
We're so excited to be here with you all today. Hello. Okay, so we'll go through a few of our learning objectives. By the end of this webinar, participants will be able to differentiate the emotional and clinical needs of key perinatal populations in order to enhance assessment and treatment planning across counseling and medical settings, evaluate the potential limitations of current practices, and identify additional evidence-based therapeutic approaches that counselors can integrate and physicians can confidently recommend to support more rapid, sustainable outcomes for perinatal clients. Implement practical, developmentally appropriate guidance that physicians can offer during medical visits and counselors can reinforce in early sessions to bridge gaps before formal mental health treatment begins. Recognize the unique mental health presentations of fathers and non-birthing partners and apply appropriate assessment strategies that reflect the differing ways the stress may manifest. Strengthen interdisciplinary collaboration by integrating communication strategies that improve continuity of care between counseling professionals and perinatal physicians, ultimately enhancing patient outcomes across the perinatal period. Recognizing key risk factors, warning signs, and protective factors unique to pregnancy and the postpartum period. Implementing safe, collaborative response strategies that prioritize patient safety, therapeutic alliance, and coordinated care among disciplinary providers, and navigating communication and referral pathways to ensure timely and effective support for individuals experiencing suicidal ideation during the perinatal period. And this is just information on our disclosure and social location. No relevant financial relationships have influenced clinical content today. Cases that you will see are de-identified or composite. This is an educational presentation only, and views expressed are those of the presenters. And there's information here on our social locations.
Thank you for introducing
And
that,
Chania will
Courtney.
go ahead. Yeah.
Thank you for introducing that, Courtney. So I want to make sure that we're all diving into the webinar from the same framework. So whenever I say, or we say the perinatal period, we mean pregnancy through the first year postpartum. And I want to be clear about that because a lot of what we're talking about doesn't just show up, after pregnancy or during pregnancy. It shows up anytime in between. And it can start during pregnancy, it can worsen during pregnancy, and again, it can shift across that entire window. So I think that's really important to name. And then when I say PMADS, I mean something broader than just postpartum depression. I know a lot of times when people mention pregnancy or postpartum depression, it's the first thing that comes up. But today we're really going to be talking about the full range of presentations that can emerge during this time. And so this is going to include depression, anxiety, OCD related symptoms, the trauma responses, bipolar spectrum presentations, and psychosis and mixed clinical pictures. So, one of the things that I want us to do early is kind of widen that lens because if we're only listening for one kind of distress, a lot of times we're going to miss a lot. And when we miss the presentation that our clients are coming into, we usually are going to miss the appropriate treatment fit for them too. And in our work, if you work with the perinatal population or, women that are postpartum, you're already seeing these experiences in the rooms that you're in. This is across from birthing parents to dads and for their partners. So if someone tells you I'm depressed or I feel constantly on edge or I can't stop thinking about what could go wrong or my body just won't settle down, I feel like I'm just always scanning for danger. All of those presentations still belong in this conversation. And there are some statistics here listed on the slide that kind of show you how often this is showing up. So 1 in 5 women and 1 in 10 men may experience depression or anxiety during the perinatal period. So we want to make sure that we're looking at both of those populations. And once we widen that lens, we really have to, kind of reckon with the gap between what someone is actually living with and what they feel safe enough or prepared enough to say out loud with us as providers in the room. Next slide. Okay, so the waiting period before disclosure to me is really important because I think as providers, we can either open a door or close one. And a lot of times we don't really realize which one we're doing in the moment. When someone comes into our spaces or, whether you're a provider, a doula, a nurse, a therapist, a lot of times patients already know something's wrong before they ever tell us about it. And the reason that a lot of people wait to ever discuss what they're experiencing or what's going on is not the lack of insight, because you can tell when something, is different or has shifted, but they're kind of trying to figure out, is this space safe enough for me to be honest about what I'm experiencing? Will I be judged? Is this person going to believe or misunderstand me? And, will I be seen as unfit or unsafe? And a lot of times, if someone is going to talk to us, they're going to be fearful about what they say out loud is going to confirm about themselves. So they're afraid about what it means about them as a parent or what it could mean about them as a parent. So they're not disclosing in the vacuum. They're disclosing what they're experiencing inside systems, relationships, the power dynamics that are showing up in the room, cultural expectations, and the fear that may be accompanying all of those things. And so this is what it looks like when somebody's hesitating. They're trying to figure out, is this safe? Is me being honest going to cost me something that I can't afford to lose, whether that's custody, hospitalization, or just not feeling heard again? And so I really want to name that safety, being relational with the person that's across the room from you, is going to determine whether somebody opens up, not the symptoms. You know, um, if you've ever had a patient, and they come into your office and you've seen them a couple of times and now they're like, okay, on my third visit, I'm going to open up the floodgates and tell you everything that's been going on, and you're like, okay, you said has been going on for a while, but I've seen you 3 times. These are the things that's going on in their head. They're testing to see if it's safe and if we're creating that sense of safety. And so that's really what this slide is about. So um, I'm really curious, in your setting, what gets in the way of honest disclosure from your clients or your patients if this is what you're seeing. And I don't know if the chat is open or not, but
And feel free
if it
to
is, feel free
respond
to,
in the chat.
yeah, feel free to just drop that in. And, as we talk about creating safety and that waiting period before disclosure, I don't think we can talk about that without also talking about the role that screening plays in that as well. Okay, next slide. So, screening. I want to be clear here because, as I kind of go into the
Fear of
talk, I'm
custody. I just
fear of
wanted to
custody.
slow us down just a minute, Chania. We had a person responding in the chat.
Okay. Yeah. Those are real worries, being involuntary committed. Yeah. I think I saw
Fear of
DHR pop up
custody
too.
is huge for sure, too.
Yep. No
No
trust.
trust.
Fear of judgment. Yeah. And all of
These
those
are
things are,
all,
yeah, go
go
ahead,
ahead.
Courtney.
These are all very valid concerns that a lot of our people come in with. And thank you for
Alone.
naming that.
Yeah.
Yeah.
Shame and fear-based reasons. Absolutely.
Hmm.
Yeah. And as we, kind of get into the, a lot, yep, DHR. Absolutely. Family retaliation. These are real issues our people are working with every single day. Like how do we create that safety to where, when somebody is so fearful of these things that we build this relationship with them that they can be open and honest. I approach therapy from a relational lens. So I think building that relationship, even if your visit is only 15 to 30 minutes, is so important. Because sometimes just talking about it and letting them know, like, hey, this is what happens if you disclose this to me to reduce some of that anxiety and that fear that accompanies the symptoms that they're having. So I think that's really important. And so, kind of along with that, when we go into screening, I'm not anti-screening. I think screening is absolutely critical because it helps us to standardize care. It helps us to catch things that we normally wouldn't, and it gives us structure to open us up doors to follow up that might not have been open otherwise, right? If we don't know the symptoms people are experiencing, we don't know how to address it. So I think screening is very important. But, kind of as a lot of you guys named in the chat, the screening is not the same as understanding, and the score is only going to tell us, the truth to the extent that somebody feels safe enough to honestly answer those questions in that particular moment that they're in your office or, right before their visit. And that gets shaped. Okay. So I think somebody said they're having trouble muting. But a lot of the things that have
Want
nothing to
you.
there, everybody on, okay, yeah. And that gets shaped by um, a lot of the things that have nothing to do with symptom severity. Um, this includes who's asking, whether partner is sitting in the room, whether this particular person has had issues prior to meeting with you, engaging in the system, if they trust the system, and if they've had dismissive or harmful experiences. All of that is going to play a role into how those screening questions get answered. So, of course, screening is important, but sometimes we need to dig a little deeper. We have to pay attention to a lot of the behavioral cues that are showing up. I personally have had clients in session where, we're reviewing a screening together and they'll say, oh, I just marked something down because I was afraid of what would happen if I answered the questions honestly. I didn't want you to judge me. And so once they felt safe enough in that relationship and had more trust in who I was as a provider, they were able to tell me, what they were really experiencing and what was really going on. And, that changes really the whole meaning of the score because now we can go back through it together and they're comfortable enough to be honest. They feel safe enough and held enough in the space with me to be able to, talk about what they're really experiencing and how bad it is. So yes, we do want you to use the screeners. Use the PHQ-9, the GAD-7, the MDQ, um, the CSSRS, the EPDS. Use those tools, but don't let the score be the only thing that, decides whether you follow up. For me, when I think of, contextual follow-up, it means, I'm not just scoring it and moving on. I'm asking, what's happening for you as you were filling this out. Some things that I might say is, were there any questions that felt really hard to answer honestly, or did anything feel too risky to mark accurately? Um, and does this actually fit what's going on for you? Because sometimes the screen gives us the number, but the conversation that you have after that screening is what's going to get you down to, kind of the truth and the root and how severe it is and how it's affecting them on a daily basis. So, I take a low score with a grain of salt sometimes because sometimes a low score doesn't mean somebody is not having any symptoms and everything's okay. Sometimes it means that they're just really, really afraid. And so we as providers have to, create that sense of safety. And in creating that safety, I also think that this is where equity has to stay in the room with us because PMAT risk detection and the follow up are not experienced equally. Black mothers are disproportionately affected, and maternal inequities also harm other marginalized family, especially those people who are in rural areas. They're experiencing structural barriers, financial strain, low resources. So, a lot of those times when we're interpreting a screen, the context has to be a part of that interpretation. When the score looks low, check your clinical instincts, check in with yourself and trust those. If they're telling you that something is off and if somebody's in your space and they're guarded, they have a flat affect or you can see like visible tension. And sometimes even if there's a partner who seems to like really just be dominating the conversation, I think it's really important to really just, stay curious and don't let the number that you see on that screener shut down the conversation that you're having with the patient or the person across from you. So, curious again, if you're willing to put in the chat what contextual follow-up looks like in your setting, because a lot of times that piece just needs just as much attention as the screening itself. And so if the score isn't the whole story, the the next question is, what are the things that people are most likely to leave out? Like, what do we need to be looking for if the score isn't telling us the whole story? Okay, next slide, please. So this slide is really gets into kind of like the meat of what people are not going to tell us as easily because when you're talking to a client, they're easily can tell us like I'm tired, I feel overwhelmed, I've been feeling really stressed, maybe notice myself crying more than usual, or not really sleeping well. And then there are, other things, other symptoms that people are experiencing that are really a lot harder to name out loud. And this isn't just because they're uncomfortable, but because these don't just feel like symptoms. These things feel like something that, is confirmation or proof of something terrible or something wrong or something I'm not doing right. And so, when you think about those things, that's kind of where you get the intrusive thoughts, the rage, people panicking while caregiving, feeling emotional numb, or, I can't bond with my baby. There must be something wrong with me. And then even that resentment piece, whether that's toward the partner or the baby, um, you'll see passive death wishes or thoughts of not wanting to be here. And those are the things that aren't just hard to say out loud, but they also feel really dangerous. Like you are telling a confession and there's this fear of what's going to happen after I tell this confession of what's happening and what's going on. And so a lot of times people just don't say anything. And if we're in those settings and people are experiencing these type of symptoms, this is what we want to know because this is really important clinical information. So I guess the real question is how do we make it where people don't feel ashamed to lead with the most important things that they're experiencing? If we only listen to what's on the surface, we'll never get the real clinical picture. We are going to have to dig deeper. We're going to have to get in relation with our clients. So for me, this means I can't just sit back and wait for people to hand me the hardest part, of what they're experiencing. When I hear the safe version, when I hear I'm tired or I'm overwhelmed, or I'm going to get curious. That's my cue to really slow down and maybe ask the question a little differently. So if somebody comes in and like, oh, I'm not sleeping well, I'm just, really like tired all the time. I feel really stressed. What feels hardest for you to say out loud right now about that? What are you most worried about that I might misunderstand? Let's name what's happening in the room and then normalize it, you know, and just, we can ask them like, what part of this have you been trying not to say? What are you holding in? And so when we get the surface level stuff, let's dig deeper because a lot of time people will tell you the truth. We just have to make room for it. We have to make it a space where they're feeling like, okay, this is somebody who's actually going to listen to me. This is a space where I can be heard. And so that's really what we want to do, especially when we hear those surface level symptoms, is to see, okay, how do we get down to the meat of it? And so before I move into some of the more hidden and easily misunderstood presentations, Courtney is going to kind of just ground us in the distinctions people hear about early on, which is baby blues versus postpartum depression.
Hey, thank you so much, Tia. So we want to talk a little bit here about the how do we spot whether we have a postpartum issue emerging. Um, Baby blues is common and prevalent in the 2 weeks following birth. Those symptoms during that period include irritability, mood swings, anxiety, difficulty sleeping, and or crying spells. And these symptoms are often correlated with exhaustion and sleep changes, as well as emotional adjustments to this huge new role that people are navigating. Um, Beyond this 2 week period, if we are seeing manifestations of different things such as persistent sadness or low mood, anxiety, crying spells, fatigue, difficulty bonding, changes in appetite or sleep, we want to do a deeper dive into what's happening there because we may have the emergence of some postpartum issues. Something that we really want to discuss with our clients, and hopefully we've gotten these individuals prior to birth taking place. But if so, the protocol is the same. We just need to slow things down and how we work through these. But the two biggest indicators of postpartum issues are sleep and resources. So if we've had the privilege of meeting with these individuals prior to birth, we're doing a lot of front loading regarding these two areas to make sure that we're prepared to address these areas. Um, Following birth. But what we want to do is we want to post birth, but some of these things can be validated and normalized on the front end as well. We want to encourage psychological shifts to reimagine in the sleep process. We want to acknowledge the frustration of not being able to sleep according to traditional sleep patterns. We want to highlight the temporary nature of the current circumstances while also validating the heart inherent in it. We want to include the partner whenever possible in the plan for center and sleep. And we want to constantly reaffirm the fact that you get to be important too. There's often a feeling of invisibility post birth for a lot of birthing individuals, and we really want to reinforce that message of you get to be important too, along with these other responsibilities, not in place of, which is often the fear for people. In terms of resourcing, we want to help with identification of the resources or those resource strength areas. There's often a collision noted between overwhelm, guilt, and anxiety following birth. We want to discuss the potential benefit of listing in relation to various tasks and maybe triage to determine tasks that they're willing or able to release. This is something that if I have the privilege of meeting with someone prior to birth, that we go ahead and start working on in preparation. It's we switch between calling it a delegation list or a post-birth plan as part of their post-birth plan. What they'll do is we work through together what are some tasks we can go ahead and anticipate following baby's birth? And we jot those things down. We figure out, in terms of their community resources, that may be family, that may be friends. We figure out who may be the best individual to pair with those tasks if needed or if asked. And we go ahead and create a list of those tasks paired with those individuals that would fit best for it. Works pretty well as well post birth. It's not abnormal for family and friends to want to support or even want to be a part of the process after the birth, but they lack clarity in reference to what this may look like. So this lingering question inadvertently contributes to increased pressure in regards to decision making post birth for the birthing individual and their partners. But it also leaves, their village wondering, how they can connect to them in a new way. And so, what this delegation list does is it addresses both. It takes that pressure off regarding the additional decision making of what can I do when people are asking post birth. Um, it also delegates some of those tasks to shift a little bit of that pressure there in regards to doing all the things. And it helps the family members and friends or these stakeholders for the birthing individual and their partner. It helps them figure out a way to connect to the process and support in a way that's helpful. And so we really want to, I think it's very important to just remember sleep and resources. Those are two things that we want to be talking about. If we have the privilege of meeting people before birth, we want to go ahead and start front loading in reference to those two areas and figuring out how can we reimagine sleep? How can we connect you to the resources, both familial resources, if available, community resources? How can we link people with the resources that they need within their communities? And if we're doing that post birth, it's the same thing. Are we trying to force maybe sleep patterns into a reality for us that just doesn't work anymore? So, how do we normalize and validate the shifts there and walk with our clients to get to a place of reimagining how we can get our needs met in this new reality we find ourselves in? And Chania, I'm going to go back to you for perinatal OCD. And we can't hear you.
Thank you. Just over here talking. But yeah, perinatal OCD is one of those presentations that gets missed a lot more often than it should. It gets collapsed a lot of times into just general anxiety, and sometimes it gets responded to with a lot of alarm. And so, both of those spectrums and those responses really kind of miss the mark in the ways that matter for our clients. So, what I want you to notice here is that the issue is not just the thought itself. It's what the thought starts to mean to the person over time. The thought does get sticky. It can get loaded, and it does involve a lot of terrible, scary things about what it may mean. What it may mean about the person, or what they fear that it means about them. So, just some of the core nature and obsessions. These can newly emerge during pregnancy, postpartum. They often can center on harm, contamination. Okay, I think somebody dropped out. Sexual intrusions, responsibility, loss of control, and, again, what the thought means about that person. And so they're asking themselves, what if this means I'm dangerous? What if this means I can't trust my own mind? What if having this image means something bad about me as a parent or a person? And it can involve, again, thoughts, images, urges, or doubts, and then center around, some of the themes of harm, contamination, responsibility, or what that thought seems to say about the person that's experiencing them. And because the doubt feels so threatening, that person starts to try to get certainty or prevent harm through, checking, researching, seeking reassurance. They may start avoiding certain situations or caregiving tasks and reviewing the same scenarios mentally over and over, and just other kinds of quiet mental rituals that may look like, from the outside, they're just being careful. Um, but in perinatal OCD, the person is usually scared of the thought, they're trying to get away from it, not move towards it. It's unwanted, it does not align with who they are or their values. And that distinction is the most important distinction we can make. So if somebody keeps asking, some version of the same question because they're trying to feel certain, or if, they're doing a lot of quiet internal checking that never resolves, we don't want to just automatically assume that that is anxiety. I want you guys to start thinking about OCD because, that's where referring them to the right sort of treatment is going to make all the difference. So, me personally, I work from an ICBT framework, which approaches OCD through the lens of obsessional doubt. And I've had clients that have had severe symptoms. I mean, I'm talking like 22 on the Y box. They have severe symptoms. And they improve to the point that they no longer even meet the threshold on the Y box anymore for OCD. So I think more importantly, they were functioning in ways that they didn't think were possible before. So that's why it's important to have that accurate identification piece so that people can get connected to the right sort of treatment. It doesn't have to be ICBT. Most people use ERP, which is also extremely effective. But just making sure that we know the presentation our client is coming in with, and we have, the accurate markers, we can refer them to the right treatment. I know Courtney uses ERP, and sometimes we work in conjunction. She'll tackle ERP and then send them over to me for ICBT, and they're cleared. So sometimes it's a two clinician approach, and I want to put that right next to perinatal anxiety because the content can overlap, but the process underneath perinatal anxiety is a lot different. Okay, next slide. So perinatal anxiety, you know, it sounds more acceptable, more relatable, which is actually part of why it gets missed so often. People will say things like, "Oh, I'm just overwhelmed. I'm just worrying a lot." But when you slow down and really listen to what they're saying, what you're going to see is this ongoing dread, hypervigilance, catastrophic thinking, racing thoughts, constant physical tension. They cannot find time to relax, a space where it feels like things are ever finished. They're going to be constantly scanning for what could go wrong. And so intrusive thoughts can also happen here too, which I think is really important to name because when a person has intrusive thoughts, it doesn't automatically mean it's OCD. What helps me kind of make that distinction isn't just the content of the thought, it's what kind of starts to show up afterwards. In anxiety, the person is usually embedded in a broader pattern of worry, physiological arousal, and there isn't a ritual cycle. So if you find someone who's mentally checking, um, worried about what the thought may mean about themselves, then that's when you want to kind of start looking to OCD. But if there's no ritual cycle organized around identity, trying to get certainty about something, and again, what the thought says about themselves, then it's most likely, or it could lean towards perinatal anxiety. In OCD, the thoughts are going to be way stickier, way more loaded, and tied to questions about meaning, identity, moral identity, and it's going to be a thought that keeps the person locked in this loop. So if someone sounds like they're living in a constant pre-disaster mode and they're always bracing, always just scanning and trying to stay one step ahead of something bad, that's a really good signal that it may be anxiety. And then, of course, for anxiety focused treatment is going to be a better fit in that case rather than automatically, trying to reach for the OCD approaches. So, the physical and cognitive load will kind of tell you, what's happening and how you can really make that distinction. I think there's a huge risk of minimization because a lot of times the anxiety piece looks like, you know, just being a parent, but we want to really look deeper into how is this affecting this person on a daily basis and how is it affecting their lives. All right, next slide, please. So, intrusive thoughts, OCD, and anxiety versus psychosis. This slide is probably one of the more, for me, especially on my side, really important clinical distinctions to make because getting this wrong in either direction can be really significant. If somebody tells us they're having a terrifying thought, urge, or image, and we respond as though they've just disclosed something that's psychotic, we're going to shut down disclosure. They're going to probably be full of shame. They're not going to trust you, and they may not return. And, in just doing that, we don't just miss the clinical picture, but we teach that client that them being honest with us is dangerous. And they're going to remember that. So the next time they experience something like this, they're going to be less likely, regardless of the provider, to bring it up or disclose. So what matters here is not just what the thought is, because remember in OCD, you can have thoughts of harm around sexual intrusions, around those different things that can come up. It's how the person relates to the thought. In OCD, it's unwanted, doesn't align with their values. Intrusive thoughts are also going to be unwanted, involuntary thoughts, images, urges, and that feel disturbing and out of line with the person's values. In OCD and anxiety, sometimes the thought is unwanted. It's going to be ego dystonic and genuinely frightening to that person. So we want to make sure insight and reality testing are both intact. They know that the thought is disturbing. They do not want it. And they're usually trying really hard to avoid it or neutralize it in some way. And me personally, I've had some moms, break down in the room because they thought there was something wrong with them just for having that thought. And how often are people holding this? They were not describing intent. They were describing being fearful, being ashamed, and worried about what that thought meant about them. And that's why I think it's really important to normalize the intrusive thoughts that come with OCD and anxiety. And I think a good book that does that is this book called Good Moms Have Scary Thoughts. If you encounter someone who needs, just that normalization piece, or even you as a clinician wants to kind of normalize that. There's a section that I think I talk about the book and the author. Her name is Karen Kleiman, and she's an MSW. I actually have the book here. I use it with all of my moms. So, yep, it's an amazing book. It's really good for normalizing this. So, it just helps to normalize something that a lot of people are going to be feeling really ashamed about. And it gives us language and them language to experiences that they're afraid of and that they wouldn't normally volunteer out loud. The book is called Good Moms Have Scary Thoughts. And the author is Karen Kleiman. I think it's on our resource slide as well. So at the end of the presentation, y'all will get a copy of all of our references also. So psychosis is a fundamentally different picture. So this is where the reality testing is going to be impaired. The belief feels real and is convincing. And they feel like they're aligned rather than feeling frightened and unwanted. So this is where you're going to encounter the hallucinations, the delusions, some confusion, or disorganization is going to be present. And the reason that it's really important to make the distinction between intrusive thoughts, OCD, anxiety, and psychosis is because psychosis is a psychiatric emergency and it requires a completely different level of response. So, the content of the thought is not enough information to know what you're dealing with. You're going to have to assess what is this person's relationship to this thought? Is their insight intact? Do they have insight? Is their reality testing intact? And, are they frightened by this experience or does it seem more like they're living inside of it as though it were true? And so I think, just really naming that, making sure that you're checking, what is their relation to the thought is going to make all the difference because you don't want to miss something that's a psychiatric emergency, but you also don't want to frighten someone who's just having intrusive thoughts or OCD into never disclosing again. And, with that, I'm going to hand it back to Courtney because hidden distress doesn't just stop with birthing parents. It shows up in fathers and non-birthing partners too, and she's going to speak to that next.
Thanks, Nia. Yeah, we want to talk a little bit about fathers and non-birthing partners. Oftentimes, this becomes the forgotten population within the perinatal mental health community. Um, One of the things that it's important to recognize is 10% of new fathers experience postpartum depression. That risk increases by 50% if their partner is also experiencing postpartum issues. 5 to 15% of fathers may develop anxiety disorders or PTSD within the first year following birth. And these individuals are typically present throughout the care process for the birthing parent, but they're absent in the assessment process. And so a lot of times these are our individuals that are falling through the cracks when it comes to assessment, when it comes to diagnosis, and when it comes to treatment. First-time fathers are twice as likely to exhibit postpartum symptoms when compared with experienced ones. And it's also important to note that the manifestation of the symptoms for non-birthing partners and dads may look substantially different. Instead of maybe a more typical presentation of sadness, symptoms may look like unexplained anger, irritability, impulsivity, overworking, addiction, either worsening or emerging during this time period, restlessness and or withdrawal. The distress doesn't affect the birthing parent solely, just as there are hormonal changes that impact adjustment for the birthing partner, non-birthing partners experience hormonal changes as well. One of the things in terms of treatment that we really want to do when possible is engage the partner as much as possible. We want to protect the space for the client, but try for at least in a therapeutic space. We want to try for at least one session with the client's permission with them both together. The goal of engaging the partner includes increasing support for the client, observing dynamics, supporting exchange and communication of needs, offering affirmation and validation to the various roles that they're both experiencing, and potentially linking the partner for services, not to mention the emotional connection and working towards strengthening that during this process is incredibly powerful in terms of insulating and decreasing some of the symptoms that may be emerging. Next slide, please. So what might a struggling non-birthing partner look like? They may look like an individual that's having trouble bonding with the baby. There may be increased engagement in impulsive or avoidance-driven behaviors. There may be difficulty sleeping or restlessness, change in appetite, feelings of worthlessness, confusion, or guilt in relation to their role, loss of interest in hobbies or social activities, persistent irritability or anger, or thoughts of self-harm. I think it's really important to name as well that the feeling of invisibility is something that is a struggle for both birthing and non-birthing partners that we need to address as well. Next slide, please. So how can we help? Individual needs balance with emotional connection. There's often a guilt noted in relation to thoughts of self during this period. We want to constantly be given those reminders that you get to take care of you so that you're in a position to take care of others. Hopefully we've started this message even prior to the birth, that you get to be important to, not instead of, but in addition to. Examples may include working with partner and other stakeholders to create intention moments of refuel, which may include but aren't limited to participation in groups, occasional exercise, protected moments of quiet, a solo or a couple's walk together. or protected time to tend to basic needs such as food and naps. Um, and so we want to make sure that we're working with the clients to create intentionality around what can they do to refuel themselves, to put themselves in a space to be able to do the important things that they're needing to do in this new role on a daily basis. That's going to look differently from person to person. And this is where we get curious. What does refuel look like for them? What helps them feel energized? And it doesn't have to be huge things. If you notice, part of what I just named was, a protected space of quiet. Maybe a walk, either solo or together with their partner. And so it doesn't have to be big, huge things that we're looking for, but these things become big, huge things for our clients. They're the fuel that allows them to be able to show up in the way they want to show up in all these other relationships that they're navigating in this new role. We want to go back to exploring the sleep hygiene and other basic needs areas. It's not uncommon for people to inadvertently neglect their basic needs during this period. And we want to remember, just as with our birthing partners, for the non-birthing partners, those indicators for postpartum, it's going to go back to sleep. It's also going to link to resources, and is their partner in a space where they are struggling with postpartum symptoms emerging? That's something that we want to pay attention to, particularly for non-birthing partners, because we know that the prevalence of them experiencing postpartum issues increases by 50% if their partner is in the midst of a struggle. Encourage peer connections to reduce isolation. That balance of paying attention to your needs. Normalize and validate the experience of non-birthing partners who struggle. We want to bring attention as well. We want to validate and normalize the difficulty in creating the balance, because it's not easy, right? Especially in the weeks and months after bringing baby home. And what that looks like in one moment may change. I mean, think about the changes in sleep patterns for baby, all of the changes that go with the postpartum period, things that we may discuss that may be helpful and work this week. We may need to recalibrate and repaint that picture 2 months, 3 months, 2 weeks, 3 weeks from now. And we want to prepare our clients for that as well. We want to normalize that experience. We want to validate the hard evidence within that. And we want to partner with them, to figure out how to create this balance, contentment, and joy in daily living in the midst of all that they're navigating. Next slide, please. This is a continuation of how do we help. We definitely want to include fathers and non-birthing partners in our screening process. Postpartum doulas can assist by providing focused education for those individuals in regard to newborn care, support, and building confidence in their partner, as well as the parenting role during this transition. We want to link with resources. What's out there in terms of providing help for our families. We'll have a resource list that's available in later slides that includes things like sleep training experts that can help with providing wraparound services for our clients. We have dad doulas. And so what resources in terms of community resources are out there to help provide the services that our families desperately need? We want to normalize the counseling process, normalize each individual within the birthing relationship, getting to be important too, along with not an abandonment of other responsibilities. We want to provide reminders in a gentle but validating way that this is a chapter and not the story. And we want to aid in identification and affirming of the non-birthing partner's role during this period. So we'll meet Marcus today. Marcus is a 40-year-old male who presents for counseling due to a long-standing struggle with what he reports was previously diagnosed as sex addiction. He explains that the urges and compulsive behaviors first emerged shortly after the birth of his oldest child, now 20, with his ex-wife. Marcus describes that period as overwhelming. He and his first wife had 3 children within the first 5 years of marriage, and he recalls feeling both proud of becoming a father and simultaneously unprepared for the rapid changes in responsibility, identity, and intimacy that followed. Over the years, Marcus reports that the urges have been cyclical, disappearing for long stretches, then suddenly coming back out of nowhere. He notes that these episodes often coincided with major life transitions, though he's never fully understood the pattern. Marcus has been remarried for several years and recently welcomed a 7-month-old baby boy with his current wife. Until the past few months, he describes the relationship as the happiest and most stable he's ever experienced. He reports feeling deeply connected to his wife and proud of the family they're building together. However, with the arrival of the new baby, Marcus has noticed the return of the same urges and compulsive thoughts he experienced decades earlier. This resurgence has left him feeling anxious and ashamed. He fears that he's slipping into the same patterns that contributed to the breakdown of his first marriage. He emphasizes that he does not want to repeat the past and is seeking counseling now because he wants to understand the root of these urges, regain a sense of control, and protect his relationship. Marcus appears motivated for treatment and expresses relief at finally addressing something he's carried privately for many years. He hopes therapy will help him break the cycle he feels trapped in and develop healthier ways of coping with stress, intimacy, and the emotional demands of parenthood. Next slide, please. So, what do we think is happening with Marcus? Feel free to opine in the chat, but what are your thoughts on Marcus here? What could be happening? What do you feel like could be helpful? And how are fathers or partners currently included in mental health conversations in your setting? Absolutely. Great awareness and strength to seek support. Hidden distress associated with being a father. Shame. A lot of shame. And Marcus is here to do the work. He wants to improve his relationship. Distress and shame. Yeah. And what we're finding in Marcus's case specifically is that these periods of urges for him coincided with the birth of each child. Absolutely. Fathers are not usually included in many mental health conversations in the inpatient hospital setting. He's returning to an old pattern to gain relief. And so, one of the things that we would explore with Marcus here, anxiety followed by relief, absolutely. And how we approach things with Marcus certainly may look differently, from provider to provider, specifically depending on how you view these clients, and what modality you use to help bring relief. One of the things that I would apply here, because I have a basis in EFT which focuses on attachment, is we would explore how attachment needs have shown up for Marcus and what that's looked like in this transition post birth for him, and examining what those urges have looked like and the origin of those. What does it look like in some of you all settings? What would be the approach here? Are we seeing a lot of dads or non-birthing partners come in? Maybe not with this level of insight, but are we seeing a lot of these individuals come in seeking help within our various settings? I've seen one person comment regarding the inpatient hospital setting. What does it look like in treatment of these individuals in private practice or in community mental health? Mm-hmm. AEDP, very similar in a lot of ways to EFT in terms of reflecting the vulnerable emotions. Not for me, sadly. The dad's partners I see are usually coming in because they're coming in as a couple. Absolutely. That's how we typically see these people, right? And this is an opportunity for more assessments as we're seeing our couples come in. Yeah. This is going back to one of the previous slides where we were discussing they are seen as couples. Absolutely. This is why it's so important, even if you have someone come in, a birthing partner for individual therapy, to see if there's the opportunity there to engage the partner. It's not just, I mean, it's absolutely important for being able to assess and identify our fathers and non-birthing partners who are in the midst of a struggle, but it's also an increase in connection for the birthing partner as well. So there's huge benefits all the way around to engaging both in treatment if possible. Mhm. Next slide, please. So we're going to transition to discussing. Oh, I'm sorry. I see one more person in the chat. I have one dad who comes in, but it's not postpartum, and it is child related, though. Absolutely. We're going to transition here to discussing our other special populations. Those today will include fertility issues and loss, trauma in the perinatal period, and suicidal ideation in the perinatal period. According to the CDC, infertility is defined as the inability to conceive after 1 year of unprotected sex or after 6 months if a woman is over age 35. Key factors during this period include the waiting periods, disillusionment, layers of loss, the grief process, trauma, and support. In regard to the waiting periods, we really want to bring attention to what these time periods entail. Waiting periods can include, but aren't limited to, hormone testing, egg retrieval cycles, positive pregnancy results, HCG measurements, medication approvals, transfers, then after successful transfer, when the pregnancy. Um, we will talk a little bit more about that. Disillusionment and layers of loss. There's often grief associated with concrete and abstract loss experience during this period, including but not limited to failed treatments, inability to conceive, loss of their family member, loss of the experience they expected or hoped for, loss of innocence regarding what can go wrong. Um, it doesn't matter if a statistic says 5% or 10%. If you've been a part of that 5% or 10%, the perspective on what that looks like looks very differently for you. Loss of joy in the experience or joy replaced with anxiety during pregnancy. Perceived loss of the ability to express their pregnancy experience. For example, a client that may have experienced a healthy pregnancy following fertility issues or loss, but feels guilt regarding discussion of a difficult day in the pregnancy. or post-birth due to internal or external pressure to feel grateful that they've made it to this stage. I think about a client that was struggling with HG, um, following following, a prolonged period of difficulty in relation to fertility, and didn't feel like she could express what that experience looked like for her, um, for this feeling of needing to be grateful, or to only display the gratefulness, about being in the midst of a pregnancy. Next slide, please. So, fertility issues and loss, navigating those waiting periods. We want to ride the roller coaster of emotions with our clients. We want to normalize, validate, affirm, support, and wait. We want to wait with them. We want to partner with them in that process. We want to walk the journey with them. We want to create an intentional space to process grief and loss in collaboration with the client. We want to resist the urge to fix. We want to follow the client's emotional lead with balanced responses. We want to teach stakeholders to sit in the heart with the individual. There's probably many individuals, either within that village and sometimes outside of their village, that, are wanting to help. They just don't know how. And so we want to take the opportunity, with the client's permission, to teach stakeholders how they can sit with this individual and support them in the midst of this process. Identify and encourage utilization of coping skills or resourcing. Learn and increase implementation of grounding and mindfulness techniques. Anxiety tends to flourish in situations where we feel out of control, and waiting periods, are plagued by, that feeling of being out of control or powerless. And so we want to focus on locus of control and how we can, shift focus to the present and things that are within our control. We want to create mental escape hatches or intentional distractions. Worry boxes have been hugely beneficial, setting aside intentional spans of time where it's okay to work with those periods. It has a beginning and an end time. It offers reassurance to the brain that we are gonna focus in reference to these areas. We're not gonna forget these things. And so the person has this period where they're able to lean into all the things that are coming up for them in terms of worry about the experience. But we want to combine that with coping or resourcing skills so that we can put the top back on the box at the end of that period. They can release it, they can shift focus and help with the formulation of boundaries. We want to help support them in what that looks like. Some other things that have been helpful are balanced journaling. And when I say balanced journaling, there can be the tendency to journal, but only focus on the negative or uncomfortable emotions that are coming up for us. And so we want to promote balanced journaling that includes both the anxieties that are coming up and the uncomfortable emotions around the experience, but we want to balance that with the hopes as well. Writing letters to the baby that they hope to meet. Again, worry boxes have been something that's incredibly helpful. It aids in releasing said worry during the times outside of this period by offering reassurance to the brain that there'll be time for such. It offers a period of time to give in to the worry, reducing avoidance, thereby eventually reducing overall anxiety. And when the worry period is over, we want to have identified activities to shift into that promote mindfulness or grounding, to bring us back into the present, to fight back against that anxiety being experienced in those periods. It's a version of exposure therapy. Next slide, please. Layers of loss. So what we want to talk about here is abstract loss, the intangible losses experienced, which evoke emotional responses or grief responses. Um, Examples include disillusionment in regard to the pregnancy journey, loss of innocence in regard to what could go wrong, loss of a previously available birth plan, loss of having certain individuals present, such as in natural birth versus C-section, loss of the experience of being discharged with baby, grief in relation to partner's role in this stage of the journey, loss of hope in relation to pregnancy. The list goes on. These are the losses that you can't see, but they matter just as much as the losses that we can. And we definitely want to make sure that we create a space that promotes talking about these things, talking about these abstract losses, these invisible losses, and bringing attention to these losses, bringing them to the forefront so that we can process through those in a space that feels safe. Another significant loss during this period is loss of my loved one, loss of a child during any stage. And I just want to ask here, when you think about abstract loss in the context of your settings, are there any abstract losses that aren't mentioned here that you've seen show up for some of your clients? Loss of the future they thought they were going to have. Loss of the typical journey they expected. Coming home to an empty nursery, absolutely. DHR involvement removal of the infant at discharge, absolutely. Thank you all. Fear of losing the marriage, failing because the pregnancy was lost, absolutely. We need to be able to name these things with our clients and address them in a space that feels safe. Avoidance, not wanting to face the reality, absolutely. Next slide, please. The role of trauma in the perinatal period. According to APA and Shapiro, the EMDR definition of trauma is a past disturbing experience that hasn't been adequately processed, leaving the memory stored with intense emotions, thoughts, behaviors, and physical sensations that yield psychological distress. Common trauma manifestations during the perinatal period include attachment wounds, loss, birth trauma, depression, anxiety, and OCD. So we're going to meet Alyssa. Alyssa is a 27-year-old first-time mother who initially sought counseling during her second trimester to address escalating anxiety related to pregnancy. She described persistent worries about her health, the baby's development, and her ability to cope with the transition to motherhood. Since beginning treatment, she's shown meaningful improvement through a combination of CBT and EMDR resourcing. She reported feeling more grounded, more capable of challenging catastrophic thoughts, and increasingly confident as she approached the end of her pregnancy. At her 37-week prenatal appointment, Alyssa and her husband were unexpectedly informed that she'd need an emergency C-section due to preeclampsia. The news was shocking for both of them. Up to that point, Alyssa had experienced what she described as a perfect pregnancy. No complications, no warning signs, and a strong expectation of having a natural, unmedicated birth. The abrupt shift from anticipation from anticipation to crisis left her feeling blindsided and powerless. Next slide. The delivery itself proceeded without major complications, and aside from a brief episode of jaundice, both Alyssa and the baby recovered well. 3 weeks postpartum, the family is home and physically healthy. However, Alyssa reports that emotionally she struggled surrounding the birth experience, noting that the sudden loss of control and the medical urgency have contributed to intrusive thoughts, moments of sadness, and vivid flashbacks to the day of the delivery. She shares that she often feels disconnected from the joy that she thought she would feel during these early weeks with her baby, and instead finds herself preoccupied with what should have been. And she worries that she is missing out on bonding moments she long imagined. Alyssa expresses guilt for not finishing that her anxiety, previously well managed, has resurfaced in new and unexpected ways. She remains engaged in therapy and is motivated to understand her emotional reactions, process the traumatic aspects of the birth, and regain a sense of presence and connection during this period. Next slide, please. So, what are our thoughts on Alyssa? What might be helpful next steps based on what's been discussed through this point? And Alyssa's a pretty common presentation. Storytelling about the birth, absolutely. Because Alyssa's already been prepped with resourcing prior to the birth, this is a great opportunity to head into EMDR reprocessing, potentially for Alyssa. Let her process the birth, absolutely. Allow the space to grieve the loss of what might have been. Mindfulness techniques and grounding, absolutely. I think all of these are very helpful suggestions. And we know, particularly, if there's a provider that's trained in EMDR, if we were to implement resourcing here, we know that the closer that we can get and reference to the trauma experience, the fast support our clients and moving through the processing of those moments and bringing down those level of disturbance associated. A worry box for worries moving forward, absolutely. What did she feel like she lost by not having control of the outcome? Absolutely. Shifting that focus to highlight the abstract loss inherent. Very relatable. Would normalizing her experience possibly be helpful? Absolutely. In fact, in perinatal mental health specifically, there's a difference in how we view disclosure. And I've absolutely had a client in my office, because this is not just Alyssa's story. A good bit of this was my story as well. And so being able to share, that although those experiences are different and what that looks like in terms of the processing is different, you want to normalize that emotion and share that you understand what that looks like for the client. That can be extremely helpful. Because a lot of times our clients, particularly in the perinatal space, families feel very isolated. Next slide, please. And we are shifting to suicidal ideation in the perinatal period. Suicidal ideation is a significant concern during the perinatal period. According to the NIH, suicidal ideation rates during this period range from 7.2 to 12%. Suicide is a leading cause of death during the perinatal period, with death by suicide accounting for 20% of postpartum deaths. Our risk assessment needs to include the type of suicidal ideation, passive or active, the frequency or severity of the thoughts, means, plan, intent. When we look at suicidal ideation in the perinatal period, in my work, there are two things that tend to underlies suicidal ideation for most people, and those two things are perceived helplessness or perceived hopelessness. That's often at the base of any type of suicidal ideation experience. So assessing for the present of that and attending to that can be incredibly helpful. When we look at passive suicidal ideation, it's a mindset of imagining not waking up or death by external circumstances. Passive thoughts of death are fleeting wishes to just no longer exist. Typically does not rise to the level of a plan or method or cited intent. The qualities of passive suicidal ideation versus active is that there typically is no specific plan to not be living, to just not wake up. Emotional distress is present and it requires support. An example of what this could look like is maybe everyone would be better off if I just went to sleep and didn't wake up. Or sometimes I wish I could just vanish into thin air. Whereas active suicidal ideation includes persistent, specific thoughts of ending one's life, sometimes coupled with a clear intent to act on these thoughts, although there can be more concrete thought patterns regarding a planned absent intent. The qualities of active suicidal ideation versus passive include a specific plan or method, intention may be present, giving personal items away, or mentally assigning caregiver duties to others. He'll always have his dad, he'll always have his aunt. That's all he needs. Resisting talk of the future, acquiring items for harm, creating distance and emotional connections, creating distance with partner, with baby, with family, with friends, deliberate actions taken towards dying. Individuals in active suicidal ideation are a high priority for intervention. An example may include, I found myself lately staring at my medication bottles, thinking soon this will be all over. Risk factors for suicidal ideation include, and I think it's important to recognize that at the top of this list, and these are in no particular order, but at the top of this list is sleep quality because it's an important predictor across the board. So we constantly want to be assessing for sleep hygiene. So sleep quality, intimate partner violence, low socioeconomic status, prior mental health disorders, prior suicide attempts, disillusionment with motherhood, limited social support, entrapment and despair, feeling invisible, helplessness and hopelessness. So what do we do? Screening can be incredibly helpful, but like Chania mentioned before, we want to include the screening with the context with our clients. Those assessments discussed have been the Edinburgh, the EPDS, PHQ-9, the Columbia Suicide Severity Rating Scale can be helpful, and asking suicide screening questions. And we definitely want to assess for sleep hygiene. Support, how can we link these individuals with resources and social support? Interventions can include safety planning, support, normalization, validation, increased communication, increased appointment intervals, bringing the stakeholders in as appropriate. medical evaluation or medication reevaluation. Evidence-based modalities that have been shown to be effective here include parts work, DBT, AEDP, CBT, ICBT, EMDR, FLASH. Some special items to consider. Um, what are those? What does that look like in you all settings? Is there anything anyone wants to add here in terms of things to consider? And the stigma associated with disclosure during this period. There's often a fear regarding labeling or removal. I think we've named that in earlier slides, but that's a real fear. And so we want to make sure that we're constantly working to create the safety in the room where possible for our clients. Tangible items that have helped. Report to the hospital as warranted. Particularly when possible when positive for plan or intent, when thoughts worsen, or when thoughts appear opportunistic, impacting safety. Help parents develop boundaries that work for them. Balance of intentionality and flexibility. Help them bring order where possible to what feels like chaos at times. Help them embrace the chaos and give themselves grace within it. Insert breaks or reinforce the tag method, but particularly between the birthing and non-birthing partner. But you can also include, extended stakeholders or resources like family members, friends that have offered to help. How can we involve people in that tag method to provide some relief? Support and link areas of emotional connection to reduce isolation. Reimagine sleep. We're going back to sleep again. Support intentionality and delegating. Symbols for indicating overwhelm and overstimulation. What we mean here is, when you're in a period of distress or crisis, sometimes you don't quite have the words, that experience and what you're needing in those moments. One of the things that I've seen be extremely helpful in my work with couples, and that can be helpful as well with individuals kind of communicating their needs with partners, is symbols. If we know that there are periods that are arising that include overwhelm, overstimulation, whatever that is, if we can talk about those things and create some intentionality around it, can we develop symbols, whether that's a color, whether that is, an animal, some particular symbol that has communication attached to it. And so these symbols can be used in place of words during these anticipated moments where both partners can be privy to what the symbol means and what the need is that's being communicated, but we don't have to use all the words. It may be as simple as texting the color purple. So, if a client texts the color purple to their partner knows what that means, and they can kick into action to try to meet the need that's emerging during that time period for that client. And also assess for co-occurring conditions, including but not limited to ADHD, harm, OCD, psychosis. All of these things can have similar symptoms that mimic, and positive future thinking, positive self-talk, affirmations can be helpful. Remember that base of helplessness or hopelessness. So, shifting focus to some of these things can be very instrumental in addressing that. How do I get to be important too? These are other tangible items that have helped. Normalize emotions and empower. Emotions are neutral until we attach values to them. They're not positive or negative until we attach that. More frequent therapy appointments, refuel moments, ideal parent exercise, can window of tolerance support FLASH or EMDR, and then some of those assessments that we talked about. And I know we are moving towards the end of our presentation today. We have included some other slides that we knew we wouldn't get a chance to make it to today for you guys, but we wanted to make the information available and be able to pull that up later. but we did want to offer just the time period for any questions or feedback that you have for us in this last minute or so.
Yeah, and as you guys think of the, questions that you may have, feel free to reach out to us to stay connected, or if you don't want to submit them here, you can submit them to the email and we'd be happy to get back to you. And if you want to kind of just keep up with us and the work that we're doing, feel free to follow us on Facebook and you can visit our website. Um, LB, can you advance to the next slide as well? And those are just some appendices for different questions you can ask to kind of just clarify the differential, and this will be included in the PDF slide version of the slides that you receive from us. And this is a support group that I am currently hosting for pregnant and postpartum individuals. So you guys can check that out as well. And LB, if you want to go back to the slide that has our contact info. Thank you all for joining
Thank
us.
you so much for you all's time today.